So our third speaker, I'd like to introduce Dr. Ju Choi from the Korean National Cancer Center. So I'm sure you're familiar with many of his prior trials, clinical trials that have really done some important contributions to primary and secondary prevention. And Dr. Park already mentioned the HELPER study, so I'm sure we'll hear about that and other evidence and trials that are ongoing. So Dr. Choi, thank you.
Thank you very much for your kind introduction. Good morning, everyone. And I appreciate the organizing committee and Professor Hwang for inviting me this important Gastric Cancer Summit. Efficacy means the performance of an intervention under ideal and controlled circumstances, and it maximizes the intervention effect. Effectiveness means that performance under real-world conditions and accounts for external factors that moderate intervention effect. So actually, gastric cancer incidence is very low. Efficacy study is quite difficult, and most of the data are from effectiveness study. As already mentioned by Professor, global cancer statistics suggest that Eastern Asian region is the highest incidence region. This slide summarizes the overview of screening programs in high-risk Asian countries. Japan started their screening program, nationwide screening program in 1983 by Efficacy series, and they updated 2018 to include an endoscopy too. In Korea, 1999, started a nationwide screening program. At first, the Efficacy and endoscopy were equally recommended, but it was updated in 2015 to recommend the EGD preferentially. China has two screening programs. One is started in 2008 in high-risk rural area, and the other one is started 2012 at high-risk urban area. China is not the nationwide screening program. They are dedicated for high-risk groups. The age is for Japan is over 50, South Korea over 40, and China 50 to 69. Interval is 2 years for Japan and South Korea, but China recommendation is from 3 years to less than 1 year according to stomach condition. This is the China study that evaluated the effectiveness of one-time endoscopic screening for gastric cancer prevention. This is the multi-center population-based cohort studied from 2005. And age was 40 to 69, and the population is 600,000. About half of them were control group, and the other half are invited to the screening program. But actually, 1/3 of them are actually screened. For non-cardiac cancer, invited person incidence is 0.88, a 12% decrease. Mortality relative risk is 0.72, 30% reduction. But in screened group compared to control, incidence decrease 0.66, 1/3 decrease, and mortality is 0.38, 2/3 decrease. This is another Chinese study that checked the beneficial effect of endoscopic screening. This is also population-based study, including over 370,000 people. Most of them are unscreened control, and only 4% were actually included in the screening group. And there are many stomach pathologies. In this study, the gastric cancer incidence was 0.69 relative risk, and mortality risk was 0.33. It was very similar to previous Chinese study. This graph shows the 5-year survival rate of repeated endoscopy. In unscreened group, 5-year survival rate is 32%, but once screened, 73%, and repeated screen shows an over 90% survival rate. But we should be careful because the number of at risk are very small, so it should be cautiously interpreted. In Taiwan, a pragmatic RCT was recently published about the screening for H. pylori to prevent gastric cancer. In this study, the authors randomized 112 persons to FIT only, a control group, and the other 120,000 people added the H. pylori stool antigen test. And then, among the invited persons, gastric cancer incidence, gastric cancer mortality was not significantly reduced. However, among the 112, 1/4 actually screened, participated screening. And in this group, gastric cancer incidence looks decreased, and gastric cancer mortality also decreased, but somewhat significance was controversial. And this slide shows the Japanese recently updated guideline, and the guideline recommend radiographic endoscopic screening are recommended for population-based and opportunistic screening, but H. pylori antibody and serum pepsinogen tests are not recommended because of insufficient evidence. The guideline conducted systemic review about cohort studies for radiographic screening. They found that incidence was not decreased, but mortality decreased about 50% in all 3 cohort studies. Also, systemic review of case control studies about radiographic screening and endoscopic screening. 2 are from Japan, 1 is from Korea. They found that endoscopies, early radiologic screening did not reduce the gastric cancer mortality into study, but endoscopy screening all reduced gastric cancer mortality. So they recommended endoscopy screening too. This is very recently published data from Japan. It's a randomized control study to evaluate the gastric cancer detection rate using endoscopy with serology risk stratification. The control group is barium photofluorography group. 1 or a 2-year interval barium study was performed, and finally at 6 years, all group has endoscopy to check the gastric cancer. In the ABC endoscopy group, A group was Helicobacter pylori negative, pepsinogen negative. In group B, Helicobacter positive, pepsinogen negative. In group C, both Helicobacter and pepsinogen positive group, and Helicobacter pylori negative and pepsinogen positive group was group D. And in group B, 3-year interval endoscopy was performed. In group C, 2-year interval endoscopy was performed. In group D, every year endoscopy was performed. And group A did not follow this group. And also found that among the 600 each group, gastric cancer detection was 12 cases in barium group and 11 cases ABC group, which means that gastric cancer detection rate was exactly same both group, but cure rate by endoscopy dissection was significantly higher in ABC endoscopy group. But the cost of the ABC endoscopy group is much higher than barium, traditional barium group. This is the synthetic control study that evaluated the effect of nationally organized cancer screening program in Korea and Japan. The left panel is about Korea. In Korea, nationwide screening started in 2002. A few years later, the red line, Korean mortality data, is significantly lower than synthetic control or other control countries. But in Japan, they started opposite screening in 1983. The mortality reduction was not significant in synthetic control and control countries. This is the Korean guideline, and I'll show the participation rate of Korean National Cancer Screening Program. In 2002, at the first year, total number of candidate persons were 10 million persons. Only 7% participate the actual screening, and about 30% choose the endoscopy screening. So 220 endoscopy was performed at this time, and 10 years later, 2022, total number to be invited was 13 million. Participation rate is 64%. Endoscopy screening actually performed was about 8 million cases. Over 90% people choose endoscopy procedure. Actually, this table shows the performance according to screening method. In 2002, endoscopy was more effective than upper GI series. It was 3.5 times more cancer was detected. In 2019, the ratio was 7.4, means that much higher in endoscopy accuracy because we have more early gastric cancers at this time. From now on, I'll talk about our national cancer program in terms of mortality reduction. Mortality reduction from upper GI series was very modest. In overall age, only 2%, it was not significant, but from 40 to 75, it is 5% mortality reduction was found. For endoscopy, almost 50% mortality reduction was found, mainly from 40 to 75. An interesting finding of the analysis was the effect of endoscopy screening frequency and interval on gastric cancer mortality. If a person got the screening endoscopy once, 40% gastric cancer mortality reduction was found. If twice, then 70% mortality was reduced. 3 times or more, almost 80% or more mortality reduction was found. And interestingly, we recommend 2-year interval endoscopy, but more longer interval, 2 or 3, between 2 or 3 years, 2 or 4 years, 3 or 4 years, more than 4 years also have mortality reduction effect. So we have to think about the proper intervention rather than 2 years. This is a trend of major cancer incidence in Korea. The top yellow line is for gastric cancer. from the 2002 for 10 years, the incidence quite stable. But the number of endoscopy performed was almost 20 times from 2002 to 2012. 2020 endoscopy procedures to more than 4 million endoscopy procedures. This means that for gastric cancer, the overdiagnosis problem might not be a big problem. In contrast, thyroid cancer, colorectal cancer, breast and prostate cancer all increased during the same time. And then after 2011, our gastric cancer incidence steadily decreased. Annual percent change was minus 4.4, and 2 years ago, gastric cancer finally became fourth most common cancer. Endoscopic resection of premalignant lesion and Helicobacter pylori prevalence decrease might be the two main causes of recent gastric cancer incidence decrease in Korea. Premalignant lesion for high-grade dysplasia or low-grade dysplasia was resected from 2010 to 2018, about 150,000 cases, means 16,000 each year. It is almost half of our annual cancer incidence. And Helicobacter pylori incidence was 67% in 1998 to 44% 2016. Means that, and have two, meaning that the birth cohort effect, and during our national cancer screening endoscopy, Helicobacter pylori are actively treated after diagnosis of dysplasia, peptic ulcer, or atrophic gastritis. This is the economic burden of gastric cancer screening in Korea. In 2002, from 2002 2022, 2010 to 2022, the gastric cancer screening burden increased more than 3 times. And it takes about 60% of whole national cancer screening program. And will further increase because our Korean population aging is become severe. To improve gastric cancer screening, targeted screening for high-risk group, and non-invasive testing for high-risk group selection, and to improve endoscopic resection is the main method to improve gastric cancer screening. In summary, endoscopic gastric cancer screening program in current China, Japan, Korea, all effective in reducing gastric cancer mortality. Due to the large economic burden for screening, further improvement is needed by adding primary prevention strategy and risk stratification. Thank you very much.